The topic of the next speaker will be on Mycobacterium tuberculosis, another stigmatizing mycobacterial infection, also associated with overcrowding and poverty. Tuberculosis is also called the White Death, and is still causing suffering, premature deaths, and challenges as microbial resistance emerges. Please welcome Professor Ma Dyrhol-Riise from Oslo University Hospital and University of Oslo.
Thank you so much for inviting me to this very nice and important symposia. I'm very happy to talk about tuberculosis, which is really, as Björn said, a very old, very, very important disease, and it is very close to my heart. So I would like to tell you a bit about what we have been doing about TB research at Oslo University Hospital for the last years, and where we have been working with translational medicine, taking samples from our patients to the lab and back to our patient in randomized trials. And we are talking about personalized medicine because we know that tuberculosis could be so much. It could be like a silent disease that we just by accident see in an X-ray, or it could be very disseminated disease with a very, very sick patient. But as you see from his chest X-ray, they are very different from normal to very much pathology. And we treat the patients with the same regimens, the same standard regimens. And it's a lot of talk about now in different diseases to do a more personalized medicine, more precision medicine, to treat each patient individually. And we had this study to try to look into that. So what they saw some years back is when you got access to PET scans, there were studies in South Africa showing that if you took PET scans of TB patients that had been put on efficient therapy and that have clinically responded, and you also took samples from the sputum, you saw that you can find mRNA in the sputum, and you saw there were PET scans positive. So these patients, they were actually having ongoing TB replication, although they were efficiently treated. So we might treat some patients too much, some patients too little. So we have to individualize, and we have to do that by making better therapy and also have what we call host-directed therapy. So we can boost the immune system to the patient to better respond to therapy. So we talked a lot about multidrug-resistant TB, and this is very important in tuberculosis. And therefore, we have to find new therapy approaches. So we can save organs, because TB is very much like lepra and some other, and also leishmaniasis. That is the immune response that's actually giving the symptoms. So we have to kind of dampen the immune responses. And we can do that by also try to shorten the time the patient has to be on this very difficult long-term therapy for host-directed therapy. And we might also boost the patient's immune system by giving them therapeutic vaccines. There are very many different approaches on how you can use different compounds as host-directed therapy. But since TB is a disease that's really hit the poor countries or the poor patients, we have to find something that's affordable. So we have to test drugs that are already there, and we have to develop therapeutic vaccines. And these two strategies have we tested out in a randomized clinical trial. So we're talking about vaccine. I just will show you this one slide, but there's a lot of important research now going on TB vaccines, which I think is really the important thing to do, both from a preventive perspective and from giving prevention of disease after you got infected, that you won't develop your TB disease and that you won't get recurrence once you treat it. But also what we have been looking at into immune therapeutic vaccines. That is, after you got sick, that we can give you a vaccine that boosts your immune system and makes your immune system respond better to the bacteria. So we got this idea also about using a COX-2 inhibitor, which is NSAIDs, anti-inflammatory drugs, Ibuprofen. It's cheap, it's affordable, see if that could dampen immune response. This was based on the study from Netherlands, not from Spain, and in comparison in collaboration with Netherlands, that looked into mice models. They saw that if they gave the mice ibuprofen, there were less inflammation, there were less reduced bacterial load, there were less death. So they hypothesized that then you have a dampening of the immune response and a better survival of the mice. This made us set up a study where we, in collaboration with Statens Serum Institute in Denmark, who's developing very nicely a lot of TB vaccines, in a mice model, we repeated what the Spanish research group had done. They saw that if you gave mice that were intravenously infected with TB, ibuprofen, or a similar compound, then they had a benefit. But if we gave the mouse infection of TB through the aerosol route, which is the most common way of getting infected, we found the opposite. We find by giving them celecoxib and other NSAIDs that we saw there were more bacterial load and not so good immunity. So it was the opposite conclusion. So it seems like the route of infection for TB is what really decides whether an NSAID could be efficient to dampen immune response or not. In parallel with my study, we set up at Oslo University Hospital a randomized clinical trial. And there we would test two approaches, test to give a COX-2 inhibitor and also test a vaccine developed by Statens Serum Institute. And I will come back to the design, but we gave some patients Arcoxia, etocoxib, and then COX-2 inhibitor. We gave some a therapeutic vaccine to patients with pulmonary TB. And over 200 TB patients in this health Sør-Øst region were screened, mostly by Christian, actually. And we finally included a bit of 52 patients. And we also have a bit of collaboration with Haukeland University Hospital in the end. So we gave this vaccine, therapeutic vaccine, that also could be used to be a preventive vaccine. And that actually boosts BCG, and it also induces an SS6-specific immunity, which is an important antigen in the tuberculosis bacteria. And this is supposed to give their long-term immunity if you elicit a Th1 cytokine response, which is a good T-cell response. So our hypothesis was that we had actually more studies in one clinical trial. We wanted to see, could a COX-2 inhibitor improve TB immunity in patients with active TB disease? The next question was, could this vaccine developed by SSI in Denmark, H56, be used as a therapeutic vaccine to boost immunity in patients with active TB? And finally, if you combine this, could adding COX-2 inhibitor and giving it the vaccine make an even better immune response? So this is the design of the study. I won't go into detail, but we have an arm receiving the COX-2 inhibitor. We have one arm receiving 2 boosts of vaccine at day 84 and day 140. And we have a control group, and we have an arm that received both interventions. And we followed these patients for like 238 days. So this was a quite a long and demanding study. And we did different sorts of lab techniques to measure T-cell immunity by looking at flow cytometry and ELISpot. And yeah, some of you people might know these lab techniques. With a lot of work and a lot of people involved. And also we do collaboration with Leiden, actually, to do the RNA sequencing. So they are also included in this. Just show you a very few data. Our first hypothesis, first research question was, could a COX-2 inhibitor improve immunity? And here you see a comparison to the group in red that received the compound compared to controls. And actually you see there's no difference. So by measuring T-cell immunity on by different assays, we could not show that there was any benefit of giving the patient a COX-2 inhibitor, although we do that in a clinic when patients have a lot of inflammation. The next research question was whether the vaccine, H56, the therapeutic vaccine that we gave on day 184 and day, again, new booster on day 140, could that give an increased immunity? And then we saw something. If you see the violet bars here, you see that there was an increase in T-cell immunity, whether we analyzed by one lab method or the other. So there seemed to be a still in TB patients with a lot of antigens, TB antigens and inflammation going on, we are still able to increase and improve immunity. And here's just detail about this, which different antigens these T-cell responses are reacting to. Both AG85B and SS6 are antigens that we find in the TB bacteria, and it was also used in the vaccine. So this means that you can improve responses to these antigens. And also looking at antibodies, we found there were more increased antibodies against the vaccine in the group receiving the vaccine than the group with just active TB. The third research question, that was whether to put a COX-2 inhibitor on the top of the vaccine could make it even better. Then we got actually the opposite answer. If you see here in green, you see that this good increase in T-cell immunity was actually reduced when we did both interventions. So that did not seem to be something that could work. So in conclusion, this was a phase 1/2A randomized clinical trial where safety is very important. We found that both interventions were safe. There were no reactions to the vaccine, although this is the first time it's been tested in TB patients with active ongoing disease. And we found in addition that the vaccine was immunogenic. It could improve immunity in TB patients, whereas the COX-2 inhibitor did not show that. This results led us into an ongoing collaboration as a partner in the EU Horizon 2020 project, where we're actually looking at different questions, whether these COX inhibitors or ibuprofen still could work if we look at larger groups of patients. And here we are a partnership with 9 different partners for 7 countries that started 2 weeks before the pandemic hit. So that was really a bit bad timing. But the work packages and the research questions here is that we are performing randomized clinical trials in South Africa and in Georgia, where we use ibuprofen and aspirin, very cheap, very available drugs. If they will work anti-inflammatory, that could help TB patients. The next question is if we could find good biomarkers telling which patients will benefit from the treatment or not. Then we're back to personal medicine. How could we kind of make treatment more detailed so it will fit each patient? And then we will put, like a lot of people are doing these days, so we use artificial intelligence, put all these big data into an algorithm and see if we can find a good answer to which patients will benefit and which patient will not benefit. So our part of this study is to look at host immune biomarkers and look at immune studies, as we did in our own study, the TB-COX study. And everything will then be collected during next year into a big analysis. And it's been very challenging during a pandemic to run such trials. They started out at 2 sites in South Africa and 1 site in Georgia. And they were delayed due to the pandemic, but finally they succeeded, and they're in the last period now of follow-up of the patients. So it's been done a huge amount of work with our South African and Georgian collaborators. So, and finally, I just want to thank the team at OUS, Oslo University Hospital. There is a lot of people involved to make a randomized clinical trial, as you know everything about. You need the technician, you need study nurses, you need the doctors to take care of the patients, and you need the statisticians and everyone. So thank you to everyone. Thank you.
Thank you.